I'm actually hosting this panel on serving the underserved as part of our National Library of Medicine traveling exhibit for all people, a century of citizen action in healthcare reform, which is right outside the doors, those big banners you see, so I highly recommend you go check those out. We also have some other exciting events planned. Our next panel is actually going to be on February 20th, if you can come hang out for that. And we also have some visiting speakers coming and a movie screening. So it's all available on our LibGuide. Also, one thing to note, just the housekeeping, because I always have to give the housekeeping. If you take snacks, that's totally great. Eat some snacks, eat all the snacks. Just sign in, because that's the thing UF makes us do for reimbursement purposes. So please feel free to take snacks, just sign in so that we know that an actual person took those snacks and not like a bazillion people. So anyways, I'm going to give quick introductions for our lovely panelists. I'm going to do this from left to right, my perspective, so it's right to left yours, because I remember how things work. And then we're going to start with a little 5-minute introduction. Everyone's going to take a turn and just sort of talk a little bit about what they do and why they're here, beyond like the 2 sentences that I have written here. So starting off on your right is Dr. Richard Davidson, MD and PH. He is the past Vice President for Health Affairs for Interprofessional Education. He was the chair of the Curriculum Committee for the College of Medicine. And in the 1970s, he was a community organizer, rural health advocate, and practicing physician in the Appalachian areas of Tennessee. So that's really exciting. And then next to him is Dr. Elizabeth DeVos, MD and PH, an emergency physician and the director of UF College of Medicine's Global Health Education Programs and the local Global Health Equity Discovery Pathway in the College of Medicine. She's lived and worked abroad teaching specialists in emergency care development and delivery. In Jacksonville, she's currently researching socioeconomic factors in patients' readmissions for sepsis. And then our final panelist, Gabriel Daniels, is a student in the College of Medicine's Medical Honors Program and has been involved with the Equal Access Clinic Network and Greater Gainesville community since his years at UF as an undergraduate. So he is graduating this May to pursue a career in pediatric oncology. Yay. So if you guys could, starting with Dr. Davidson, then moving all the way out to the right, could you guys take a couple of minutes and just describe what your work has been done, what work you've been doing working with underserved populations, that, just sort of specifically who you've worked with and what that looked like.
Thanks, Maggie. I'm going to skip over most of the stuff that I did here because it's probably less interesting. But I did chair the curriculum committee. My advisee, Helga Rippin, I think in '87 or so, actually was the person that started the Equal Access Clinic. That's how long I've been here. But I think the more interesting part is when I was a second-year medical student a year ahead of me kind of recruited me and said, why don't we, we're putting together a project to go to Appalachia. Being from Palm Beach County, I had never been to Appalachia, needless to say. And so we went up there and we developed a project that was based on community organizing and health fairs, going to communities. We managed to get a big multi-phasic screening van from the Tennessee Valley Authority, and we selected some communities with help of people who had been working up in those areas. These were coal mining areas that were essentially destitute and had no health care at all. It was 60 miles to Oak Ridge, which was the nearest hospital. And our model very quickly was that we would send law students and other undergrad students primarily to live in each of the communities for the summer, get together a community group that would find housing for the health fair people when they came through, and meals for lunches, and we'd go to, the health fairs would come around and we'd set up in elementary schools and screen people. And these vans they'd do x-rays, tonometry, blood work, and we'd screen people. We were smart enough to realize that really doesn't do very much. That screening people and feeling good about doing health fairs does very little for the health status of people that actually live there the other 51 weeks of the year. So the whole project was really based on getting these community groups to stay together. And we had law students and a variety of other people to help them organize themselves into health councils. By the time we ended up doing that, and I directed that program the second year, and by the time we finished, we had organized 26 rural primary care clinics in Tennessee, Virginia, and one in Kentucky. Almost 50 years later, I went back to the one that I went on, did a medicine residency at Vanderbilt, left after 2 years to go work up in the mountains because 3 of the clinics were at a point where they needed a doctor. So I left and went up there and practiced. And we started off with a little tiny clinic building in 3 very isolated areas. And in October, we went back up for a visit. The first director and I, we hadn't been up there in a while. And this little clinic is now, still has the same name, Mountain People's Health Councils. Now has 5 brand new buildings and 1 little old clinic that's the same clinic. They're a federally funded community health center. They have 15 providers, including physicians, dentists, PAs, nurse practitioners. They see 50,000 people a year. They had an income of $5 million. And they see 50% of the people who live in Scott County, Tennessee. And so that was pretty eye-opening, rewarding, and kind of put a nice cap on what we were doing. We have an archive at the University of Florida, which is online, has 1,000 of my pictures or so on it. Not of me, thankfully, but pictures that I took. And really the story of what we did in each location we went to, which you may find interesting.
Thank you.
Hi, I'm Elizabeth DeBoss. I'm an emergency physician in Jacksonville, clinically, and my work is in local and global health equity. I trained at UF in emergency medicine in Jacksonville, and then went on to a master's in public health and a global emergency medicine development fellowship at George Washington University. And the work that I have done has really been focused on assuring access to care across the world. Many places in the United States, even emergency medicine is a division of medicine or surgery. That's changing over the last several years, but it's a young specialty, only 50 years old here in the United States. Abroad, it's in its infancy. And so my work has been in working with governments and with hospital systems and universities in kind of building the need for emergency care and implementing those systems. I had the good fortune to work in many different countries as a fellow. And after I returned to UF, worked in Jacksonville for 6 years, had the opportunity to spend a year in Rwanda, living and working in their national teaching hospital, training the first cohort of emergency medicine residents who've just graduated and are leaders amongst the Africans as well in improving emergency care. But my work in the other parts of the world also set me up to understand the social determinants of health and advocacy for healthcare here in the United States. And looking back, I went to medical school in Ohio, did my clinical rotations in Youngstown, a steel town where there was a high level of unemployment when I was going through my medical school training. In Jacksonville, we have a large uninsured population in our emergency department, a little bit different population than we might see in the emergency department here. And so those factors of the patient's social status and how that influences their health is something that I've been very interested in, and has given me the opportunity to work with our students in the local global health equity discovery pathway to understand what are some of the vulnerable populations that we all encounter in our clinical work, and how can we work with our community partners to ensure that there are opportunities for our patients to have the best care. How do we ask the right questions to make sure that we're getting to those things that may not be obvious on the first clinical visit. And then my research has been in patient factors in readmission. So we're looking at some of the social things, our patients having difficulty with their medications, their follow-ups, these kinds of things, and can we work to improve our patients' care as an outpatient so they don't end up back in the hospital.
And last, I guess, but not least, hopefully, my name is Gabe. I'm a current College of Medicine student, graduating senior now. I participated in the local and global health equities track that Dr. DeVos mentioned. A great experience, and I guess what I'm bringing to the table today is the years of experience, almost 6 years now, that I have working with our Equal Access Clinic here in Gainesville. So a local perspective, to give you an idea, the clinic started, as Dr. Davidson mentioned, back in the late 80s, early 90s, and started as a humble single-site, small medical-only clinic that has now, as of 2019, expanded to be 4 primary care clinics and 12 specialty sites, all of which expands anywhere from regular primary medical health care to social and psychological health care services. We see, now we're over 2,500 patients annually, and this is all members of our community that are around us that, being students here at the University of Florida, we don't necessarily get to interact with, don't necessarily see as members of our community, but being in this organization and looking for and reaching out to people who don't have access. These clinics are set up in places where there are hotspots for high teen pregnancies, high infant mortality, calls to police for high domestic violence cases, things of that nature, poverty, poor healthcare outcomes. We have set up these clinics and have found populations that are in need and have started to work with them to figure out not just providing them the healthcare, but what can we do to make a sustainable change, as Dr. Davidson mentioned earlier. In my research now, I serve as the director of the Thursday night clinic that sees about 700 or so patients annually. And my research now is focusing on how our clinics and the provision of primary health care to the underserved populations can reduce the burden on our medical health care system, the emergency departments in our area, and how we can potentially, by providing these bridging services that will keep patients, general primary health care conditions at bay, will prevent them from needing the expanded and worsening services that, seeking services for these expanded conditions and through the emergency department or otherwise. So kind of a more local perspective is what I'll bring to the table.
Thank you so much. So obviously you guys are doing really great work and have done really amazing work just serving those who aren't traditionally connected to the healthcare system through sort of traditional clinics. And so I guess my first question is, this sounds super great. How do we pay for it? So I'd love you to just, if you can, spend a couple of seconds just talking about how the different clinics that you have worked for, are working for, are funded. Is it charitable donations? Is it a sliding pay scale? Like, does it take Medicaid? Like, how does this actually work on a financial perspective? So.
Well, I'm assuming you want me to talk about how things were or how things are now.
Yeah, we're probably were when you started.
How things were when I started. Well, Medicaid was relatively new. I actually worked in 3 different counties. In the total of 3 counties, there were a total of 5 doctors there. And none of them had done more than a rotating internship. This was in 1974 in the 5 Appalachian counties in Tennessee. So as much of the care was provided by public health nurses as much as it was by physicians. They did take Medicaid. They had to take Medicaid. But many of these people didn't know enough, didn't have access to even apply for Medicaid. And so when we initially started, we set up a sliding scale. We took insurance if somebody had it, but almost nobody had it. So it was a pretty extreme kind of situation, and it's not like that up there now either. So that's why it's a pretty unrealistic description of how things could be. Things are much better up there now, but at the time, got donations of drugs and gave them out in the clinic. We begged, borrowed, and stole medical equipment. We did some illegal practice using nurses, which is against some of the state law at the time. And we also distributed, which is also against pharmacy laws. So we were pretty lucky that we avoided all ending up in jail. But it's not like that anymore. But you know, whether you're talking about the Equal Access Clinic, Gabe will have to give you a reference. We actually did a study here a few years ago with the Community Health Scholars Program that I ran, in which we looked at Access. Access was a program at the Eastside Clinic when it first opened up. It provided free primary care to people that didn't have any insurance and that were regular users of the ER. And we actually looked at a 4-year study, 2 years before and 2 years after they got exposure to Access, and then we tried to figure out whether or not we saved money on ER visits by doing that. And we did. Methodologically, it wasn't a great study, but I don't think there's any question that with regard to your research, if you provide services to people, you will end up saving money in the long run.
Sure, I think in Jacksonville, if we look at the emergency department demographics, about 20% of our patients have private insurance and the rest are either public insurance or self-pay. And so we deal with some of the same problems that you would see in very underserved areas of the United States. And the government seems to say emergency department is the answer for everyone who doesn't have somewhere else to go. And by federal law, we are required to give everyone a screening, evaluation, and stabilization. But that's not the end of the story. Certainly we do our best to ensure that people are connected to resources and that we're providing good care. But it's different. I tell patients all the time, you know, for me to develop a relationship and understand whether what we're doing is working and be able to tweak things is just not possible in the emergency department setting. So we're very lucky that we have resources within our community. Our payments, in addition to having public and private insurance, the county does provide funding to help pay for patients that don't qualify for Medicaid, make too much money for Medicaid, and we do have a full-time case manager in the emergency department to help connect people to those resources, get them screened to see if they can qualify for that. Those patients that then meet that city contract are able to get a type of insurance essentially that gives them access to our UF services in Jacksonville. We also coordinate with the Sulzbacher Clinic for the homeless, and they also see patients who are not homeless but are low income. There are a couple other low income clinics in town, some volunteer clinics, so we try to coordinate and help our patients to at least find the resources that are available to them. The city and the state give funding to UF to help to provide for those patients that don't have insurance as well. So kind of a mix.
Thank you.
So with regards to the Equal Access Clinic, I wanted to start by saying we've accomplished an amazing goal by making it such that our patients don't pay a cent for the service that they receive from our clinics. At this juncture, we're able to provide them with the healthcare, psychologic, social services that we do, as well as laboratory work that we feel is necessary to make decisions about their care. We're able to provide that entirely through the funding sources that we've been able to secure. Now, what that looks like at the inception, at the start of the clinic, it was mostly grant work. You have a good idea for a service that's going to affect a lot of people, and there are grants that will support those ideas. That's where the original funding and support sort of came from. There are dedicated students who now continue to write to those people to continue to secure those services, to expand, to find new departments and new organizations, both locally and nationally, that will support these ideas and these expansions. And then outside of that, we have amazing student-run, it's a student-run clinic, so we have student-run fundraisers Particularly, there are two, one in the fall where the medical students run a mini medical school where we sort of put on a day in the life of a medical student for undergraduate students and teach them about medical school for a small cost and donate that straight to the clinic. That raises thousands of dollars in the fall, and then we have a 5K in the spring, which raises thousands. And then outside of that now, as our name has gotten bigger, our services have expanded, we've gotten recognition from the community, and now there are, we're fortunate enough to have individual donors hearing our mission and to provide this comprehensive care to everybody, and getting behind that mission and starting to provide individual and very generous contributions. Chapman Society, UF Medical Guild, the Marin family, there's lots of people now who have realized that this problem that we're all, I mean everybody up here in our community in Gainesville are trying to fight is one that's worth fighting for, and so we're now fortunate enough to have individual supporters as well.
Awesome, thank you. So you guys kind of mentioned this a little bit already, but I would love to hear you speak about it a little bit more, about some of the challenges when it comes to coordinating care. Obviously, the emergency room is there and it's available, but how to coordinate it, either specialists or just getting people connected to primary care. So if you guys could speak a little bit about, whether you did any of this, whether you do any of this coordination, this healthcare coordination, and how that actually works, as far as just like how can you send these patients to anybody, or is that just not an option with the patients that you work with?
Well, again, how it was in the 70s isn't the way it is now. The nearest surgeon was in Oak Ridge, and I had hospital privileges, but I couldn't very well go down there and see patients every day. So I developed, the nurse practitioners and I developed contacts of people that would take care of our patients. And one of them was an OBGYN who lived in Oak Ridge, Chuck Darling, who did all our prenatal care and did all our deliveries for free. And we actually visited him when we were up there in October and videotaped a segment with him. One of the things I was glad about was that one of my nurse practitioners was a pediatric nurse practitioner, because I was trained as an internist, and I was really uncomfortable with little tiny humans. And so, at that point we just, we did the best we could under the circumstances. We had a lot fewer resources than there are around now.
I think in Jacksonville, we're lucky that in our We Care network and the Volunteers in Medicine networks, we do have volunteer specialists who do provide care for those uninsured patients that don't meet qualifications to receive care in a general outpatient clinic, but certainly these are scarce resources. Yeah, so the biggest problem is trying to get people to the care that they need in a timely fashion. Patients that we are able to help seek state or local funding for their health care and try to get them on those clinic cards or the federal or state funded programs. That's really the best way to get them to the care. Although, certainly we have waiting times that are longer than we would like as well. So we try to do the best we can, sometimes making personal phone calls. But I can remember a situation where I made a personal phone call to a rheumatologist for a patient that had been initially treated at Mayo Clinic, stabilized, and then sent back to the UF system with no insurance. And the physician told me that they would personally make sure the patient got into clinic, no problem, call their clinic coordinator, and they would email with an appointment. I saw the patient back in the emergency department 5 days later. I said, well, what did they call you and tell you about that appointment? And she told me they had given her an appointment for 18 months later to be seen in clinic. So, and then when she got there, she probably wouldn't have been able to afford the medicines that they wanted her to have anyway. So certainly sometimes we have to be creative. We have to do the best we can with the partners that we have.
I'll echo that message, that it's a lot of finding people who are willing to provide the service and sometimes needing to, I guess, develop them on your own if they don't exist. So we've been fortunate that we're a student-run clinic, as I mentioned. So we have the medical students, and when we saw that our patients had a lot of dental issues, dental abscesses, poor dentiture in general, the dental school was offered to provide their services, and then we expanded into the School of Psychology, and we just kept expanding within the student body, and that allowed us to provide our services with our instructors and our teachers as our mentors and our attendings, if you will. And that allowed us to provide a lot of those specialty services that I mentioned earlier. We've since, as I mentioned, with our expansion, been able to find lots of community supporters who believe in the same mission. We have social workers who work at the Medical Plaza here in the UF complex, as well as otherwise, who now provide their services to us. They come in and they see our pediatric patients to help them navigate the Medicaid system, because it may not be that they don't qualify, just that they don't know how to qualify for Medicaid. And so helping them get reconnected to the system, and then helping our other patients who don't qualify for anything figure out what it is that their next best step is. Dr. DeVos also mentioned the We Care Network, which runs through the health department and helps us coordinate specialty care for some of our patients. That has been an amazing resource for us, but it is limited to the fact that patients have to be from Alachua County, they have to be below the age of 65, they have to have certain stipulations on their the qualifications for this program, and otherwise are left without option again. And so it's been a challenge, I think, in expanding what we ourselves can provide and coordinating the patient's care entirely in network where we can, and otherwise finding other options. If we know that certain medications are not outside of their reach, what is the next best treatment that we can offer our patients to make sure that we bridge them and get them the care that they need?
Thank you guys so much. So the next question I have is kind of a little bit, and it was sort of alluded to before about how health policy sort of impacts your care. You mentioned like Medicaid was new at the time, and I'm sure the Affordable Care Act has had some changes and maybe more recent health policy changes. So, I mean, a lot of times healthcare providers maybe don't see this all the time, but I feel like when you work with underserved populations, you're a little bit closer to the impact that healthcare policies like the Affordable Care Act, like changes to Medicare and Medicaid, or the recent change to the final rule from CMS. So if you could just speak to a little bit about how healthcare policy changes or implementations actually impacted the way that you worked with patient populations, that would be great.
Well, obviously Medicaid made a great difference back at that point in time for people. But I guess the thing that was striking to me was when I actually, more recently, when I visited this clinic group back in October, to see the impact of the ACA on rural clinics, in that, although Tennessee did not choose to expand Medicaid, they had something called TennCare, which was somewhat similar to a Medicaid expansion, and a significant amount of the income came from there. One of the interesting sidelights about the ACA is that at the time I moved up to East Tennessee, there was another clinic group to the north of me that organized in the same way. And the business director, the overall director and organizer of that was a Vanderbilt law student that worked with me named Bill Core. Bill Core ended up, after a long history in Washington, was the Deputy Secretary of HHS under Kathy Sebelius, and actually was one of the people that was instrumental in writing and designing the ACA. And he's still a member of our group and comes to our meetings. He's not too happy these days. I think the ACA has made a tremendous difference in rural areas in terms of trying to keep hospitals open, which is why in states that have not expanded Medicaid, there are so many rural hospitals closing and going out of business. They just can't afford to stay in business if they're not getting paid at all for the majority of care that they're providing.
I think, he started to mention Florida also did not choose to participate in the expansion of Medicaid. And I think in my patient population, we see that there are some more patients who are able to have insurance with the Affordable Care Act. Many of them, though, with very high deductible plans. So people may choose not to seek primary care, or just last week I had somebody in the emergency department that had been to his primary care and even a specialist a couple of times, and showed up in the emergency department hoping that I would offer him an MRI because his emergency department copay, no matter what he came in for, was going to be $250, and if he got an MRI as an outpatient, he would have to meet his annual deductible and pay for a big portion of the test. So even though the emergency test would actually be much more expensive to the system, he saw it as a cheaper alternative, and unfortunately that's not something I can offer him. So I think sometimes we see patients who are coming to the emergency department out of desperation, even if they have insurance, because they're trying to figure out how they can navigate the system under the constraints that they're working in. We see similar kinds of things happening with patients who have very expensive medications. Sometimes they're coming back to the emergency department, they get discharged from the hospital on that 1 month free brand name X very expensive medication, but when that runs out, then what happens? So I think for us, the Affordable Care Act does give more people access to primary care, but not always still in the way that we intended for people to be able to go back regularly and get the medications that are required. We've also seen more Medicaid HMOs in our community, and currently in Jacksonville we're dealing with kind of the fallout now that one of those HMOs has left the market, and the patients, some of these patients are very vulnerable and are not really very savvy in understanding what their choices are during open enrollment, and now may find themselves with an insurance that they can't use in the market at all.
I think that's kind of the same message that I would like to share. I think that, so we recently trained a new group of leaders for our organization, so I've seen some of the numbers more recently. While there may be more patients in our population that could be insured, all I know is that we have expanded the patient population that we're serving from under 2,000 to over 2,500 now in these last 4 or 5 years. So we are still needed and we are still being used. Of that, the patients that come to us, 85% remain uninsured. Alachua County tends to have a higher poverty rate. I think it's about 21.5, 21.6% is the poverty rate here in Alachua County as compared to Florida's poverty rate, which is about 16.5%. So we are a higher poverty rate here in Alachua County as well. And so those same problems arise for our patients and population here, is that they aren't qualifying for any insurance, and without expansion they aren't getting care, and so they are coming to us. Even those who do qualify for the care that is available through the marketplace or otherwise can't pay for their services, don't want to. We just opened a pediatrics clinic. They don't want to take their child to a $50 physical exam for school so that they can play sports when it takes me, I did 5 in one night and for free, because it's something that is very quick and easy. And for these patients, they would have to get on a bus and ride to the health department, 3 transfers over, pay for the ticket for them and their child, get the care, pay for the care, and come back when we are in their neighborhood and they can walk to us and they can get the care that they need for free. So I think that these things make it such that even with expansion, even with changes in policy, there is still a lot to do.
Thank you so much. So one of the other questions I have, and we'll see if this might be the final, it might be the semifinal, depending on how time goes, is just thinking of the sort of the holistic, when you've been working with these populations that aren't traditionally connected to care, what do you find to be the greatest challenge? You've mentioned several challenges, but obviously, what is the one that you are seeing most often and seems to be the most intractable as far as finding solutions, being creative, and finding workarounds?
Phew.
I know, it's a big one.
Well, the population in the mountains was a really unusual, atypical population. There were very few high school graduates at that point. Almost everyone up there had worked in the deep mines from the time they were kids and never gone to school. And, you know, when I first moved up there, I knew that there was a healer that lived in the community. And so I invited her over to the clinic, and we had a talk about, you know, trying to do something together because they trusted the healer. She had lived in the community, and I was new. And I think that, you know, having a provider that can relate to the situation that the patient is in is always an advantage in terms of the successful outcome of your care. I think that's really important. That's from a primary care standpoint. I think that's, you know, an important thing. Our goal when we went up there with our program was to give the people what they thought they needed in their community, as opposed to us coming in and saying, this is what we think you need. They wanted a black lung clinic, so we put together funding and got a black lung clinic. Not something I would have thought of. So I think paying attention to the patients and their needs and their desires is always important.
I can't echo that enough. I think that wherever you're working in the world, whatever community you're working with, we can't begin to assume that we know the needs of the community without working with them and understanding what they want. In the emergency department, I think one of our biggest challenges is access to medication. And I think, you know, the residents who work with me feel like they're getting a mini fellowship in case management, and you know, I'm the person who is always understanding what the formularies are for free at Publix and Walmart, and telling people, you know, which things have changed. And I think understanding some of those resources that are available in the community and partnering with some of these big organizations is probably going to be the answer as we go forward. The drugstores that have gotten on board with the free and low-cost medications are great, but we're missing big segments. Insulin is something that is unaffordable to most people that don't have any kind of insurance. I see patients who drop their bottle and they're like, I just don't have $400 until the next month. Can you change me to something? And we're going through looking, and you know, the best we can come up with is still something that's $50 or $100 because they're not appropriate to put them on any of the free oral medications. And so trying to figure out how to navigate these things, coming up with next best options, and keeping people going. Some of our asthma patients were able to give medications directly from the emergency department, but then that again is falling to the hospital to pay for. And so how we navigate those things is difficult, but also we have to weigh that with people coming back, getting admitted to the hospital, or having multiple emergency department visits. So it's a big challenge.
Yeah, I think I would summarize it all by saying the word access has to be at the center of it all, because whether you're living in the mountains of Tennessee or you're living in the Upper East Side of Gainesville, for you, accessing the health care and the services that you need is the problem. Whether it be that you can't afford the medications, or you can't get to Shands from where you live, or you know, whatever it is, you don't qualify for the service that exists to provide healthcare specialty services to Alachua County residents only. Whatever it is, it's access. And I think that you very much have to find the populations in need, understand, as Dr. Davidson said, what it is that they need, and then start providing specifically for those needs. And you know, finding the sources of funding, finding the volunteers in the community who are charged to make access their mission. And I think that that's what I would end with.
Thank you so much. So that was the end of my formal questions, because I want to leave time for Q&A, because I'm sure we've got a wealth of experience and of knowledge up here, and so I wanted to give the audience time to ask questions themselves before the end of the day. So we have about a little bit over 10 minutes. So if anybody who has questions, this is the time.
It's a big question. Do I need to repeat the question?
I mean, it seems like there's like what services are available to prevent readmissions for people of low socioeconomic status, basically is the real sum up of that question.
Sure, I just wasn't sure if we needed it on the camera. So I think there's kind of different prongs depending on how vulnerable we think the patients are. For those who have housing insecurity, there is a partnership amongst many of the hospitals in Jacksonville as well as UF Health in Jacksonville and the Sulzbacher Clinic. So there's actually a medically needy homeless shelter in Jacksonville where we can work with case management and the Sulzbacher Clinic to get some people placed directly into a housing area where they also have access to some medical care. But that's a minority of our patients. We have just instituted a new program with case management to screen for specific social determinants of health, to look for those patients who are at risk. In the emergency department, we take it upon ourselves to look at many of the issues that our patients have and try to predict those patients, but it's only in the recent years that it's becoming more formal, and there's a lot of work to be done in that area. So my particular research is looking at patients who have readmissions related to sepsis, so we're looking at trying to formalize how they get their medications, how they get their clinic appointments, and try to see if there's other issues that are coming up with transportation and other things to try to make sure that they don't come back again.
Can I just add, on our end, what we're doing from the clinic side is we're trying to understand, as I mentioned with our research, what patients do we serve the best? So diabetes, hypertension, hyperlipidemia, things like that that are easy, manageable primary care issues with low-cost medications available. We're figuring out what we are doing, and then we are going to be working with emergency departments, hospitals, primary care providers, and otherwise to make sure that we also help them channel their patients with these problems to us so that we can help them solve that burden as well. So I can tell you in my experience with the Equal Access Clinic in the Gainesville area, it is sort of in that way. We have agreements and partnerships where, for example, our pap smear services, if we do get positive pap smears, we need a colposcopy to follow up. We have, in the past, we had arrangements where we have maybe 2 a quarter that we can get colposcopies for free. And then outside of that, we need to pay a certain amount for that service, and that comes from our clinic's funding. And so there are certain stipulations and kind of caps, if you will, that occur that way. As far as who to contact, that's also a challenge that we face. We do the same fit testing in our clinics, and when we want to do a colonoscopy, we haven't even gotten as far as 2 appointments a quarter or a year yet. We're still working on that. So I agree, we face some of the same problems, and I think it's what has helped us so far is, like I said, as our name has expanded, people have reached out to us, social workers from Medical Plaza. We've gone back and met with the colposcopy folk with numbers and funding now from grants to provide the cervical cancer screening and women's health care. And we have kind of expanded on what we can do in that way. Otherwise, we do face the same barriers, and I think it's just kind of finding the right people and trying to, as you expand, explain to them what you're doing so that they know that the expansion is necessary. That's how it's worked for us so far.
So I think in Jacksonville, the city contract patients have access through our clinic system. So it's a different clinic than our insured patients. But again, those who have no funding, we struggle. We try to work with the community partners as well, Volunteers in Medicine and the Jacksonville We Care in the ways that we're able.
I'll try not to address the administrative aspects of things. But since I'm retired, the fact is that when the Eastside Clinic was first started, it was started by the College of Medicine. And it was not run by Sharons. And after several years of providing programs like the Access Program, which we evaluated, various administrative things happened. It ended up being taken over by Shands. Everything changed. There was no longer time for interprofessional case conferences, which they had weekly about patients that were particularly struggling. The profit motive was very different, and the philosophy was very different. So to get the kind of institutional support requires captains to do that for you, and who are willing to work toward that.
So I think we have time for maybe one more question if anyone has one.
I think one of the resources to those patients is the local county health department, but they're limited. And I think as the counties become more rural, the services in those health departments may also become more limited. It depends on the county in Florida, but again, with eligibility for care, our city contract patients are patients who live within the confines of Duval County and have been living there for the last 6 months and can provide evidence of that. And so if a patient comes to me from Baker County or Union County or somewhere else, basically I have to send them back to their health department to look for any services that might be available if it's not something that's requiring emergent stabilization.
I think that
I'm not that familiar with Union County anymore. So.
I think that from our standpoint, that's one of the most frustrating things for us is when we have a patient who comes from outside of Alachua County or otherwise, and we don't have a provider or a network that they qualify for expanded care. And so what we've done, as I mentioned before, is we've really tried to make as many services as possible available in-house, if you will. And we've started to focus our care on providing very good primary care, not just urgent care. So we don't have patients just coming to us for whatever's bothering them that day, but we schedule them for follow-up so they can come back and continue to manage those problems or those health conditions so that we can keep them at bay and try to continue to care for them long-term so that they don't need as much of the expanded and more worsening care thereafter. We have a lot of patients, especially, I know for Union County maybe not as much because their transit is a very different situation, but for the patients who we have reached, our follow-up is actually pretty robust. I think in the last 3 years, 98% of patients that have come through the Equal Access Clinic have received a phone call and a follow-up of some sort from our undergraduate program that calls them and makes sure that if they're needing a follow-up appointment, that they're scheduled and that they can come back. So we do a very good job of following up, and one of my favorite things when I was reviewing our charts recently, we see that we ask, why do patients come to us? Do they have insurance or not? What is the reason? And some of them wrote, I come to you because you're my doctor. So for these patients, they do think of us as their primary care physician, and they do come in and utilize our services. So we do have pretty good follow-up with the patients that we are providing this care for. And there are patients who I know by first name now, who I've seen over the 5 years or 6 years that I've been in the clinic that I know, and they know me, and that's just the couple years that I've been there. So definitely it's there.
Awesome, thank you so much. So we are at the end of our time, but I would like to thank our panelists for sharing their time and expertise with us. Thank you so much.
I'd just like to say one thing. Can you imagine that we wouldn't even have to need this conference if we had universal health care? Yep. Almost everything that was brought up in terms of a challenge for providing care is solved by a good universal health care system. So hopefully within the next few years we won't have to have conferences and traveling National Library of Medicine exhibits.
Yes, hopefully one day this exhibit will be more of a historical piece than
That's
the
right,
current
yeah.
issues exhibit is. So thank you again, everyone, for attending. Please help yourself to any refreshments, and the green forms in the corner, please do fill them out. We'd love to get feedback about these exhibit events that we host, what you like about them, what you don't like about them, and then as always, if you get snacks, sign the little forms so that we don't